Good afternoon, everyone. Thank you very much for making time to be part of the Department of Health's information session on the Specialist Dementia Care Program grant opportunity. Before we start, I need to let you all know that today's webinar will be recorded and we will publish the video of that as an addendum to the grant opportunity guidelines for this opportunity so that it's available for you and everyone else to view after the event as well. My name's Robert Day. I'm the Assistant Secretary for Dementia, Diversity and Design at the Australian Government Department of Health. My team's got policy responsibility for the Specialist Dementia Care Program and look forward to taking you through the program today. The other thing that's really important to do before we begin is to acknowledge that wherever we are around the country, we are sitting and meeting on the traditional lands of Aboriginal and Torres Strait Islander people, and to pay our respects to their elders, past, present, and emerging. And I extend that respect and acknowledgement to any Aboriginal and Torres Strait Islander people that are joining us today. The purpose of today's session is to provide residential aged care providers in particular and other interested parties with an overview of the Specialist Dementia Care Program, its implementation requirements, and details of the grant opportunity which is open now. It is hoped that potential providers under the scheme will consider the information that we give you today to make an informed choice as to whether to make a grant application or not. And part of that is obviously assessing your own capability to deliver this program in line with the Specialist Dementia Care Program framework and the grant opportunity requirements. I'm not going to talk at you all day today. I've got a group of people who are far more expert than I to share the stage with me. So I've got Ash Katosh from Dementia Support Australia, and Ash will discuss the target cohort, the referral and assessment of eligibility for the Specialist Dementia Care Program. Richard Fleming is an expert in dementia-friendly design and an honorary professorial fellow at the University of Wollongong. And Catherine Ioannidis is from Deloitte Access Economics, who's one of our program evaluators, and will share with you the experience of the program so far. The session is expected to run for about 60 minutes and will conclude with the opportunity to ask questions of the panel. And there's a Q&A function in the bottom right-hand side of your screen, and I encourage you to enter your questions into that as we go. Given we've only got an hour, there is a possibility that we'll only be able to get to some of the questions. We will keep a record of any questions that we can answer today and also publish them as a written addenda to the grant opportunity as well. If I can just take a moment to talk to you about the implementation of the Specialist Dementia Care Program to date. In June 2016, the Australian Government committed to establishing 35 specialist dementia care units across the country, at least one in each of the 31 primary health network regions. The program is being implemented in a phased approach, and the first phase funded 10 units that are currently operational. The first of those units, a prototype in Brightwater, WA, opened in September 2019, and a further 9 units have rolled out as a result of that first 2019 grant opportunity. If you are interested and you search Specialist Dementia Care Program on our website, you can find a list of those existing 10 providers already. We're now at the exciting point of having a further grant opportunity open for the program. We're hoping to set up a further 10 specialist dementia care units across 9 primary health network regions. One of the reasons that we've taken this phased approach to implementation is so that we can learn from both in the department and providers the experience of the earlier phases of the program. That's one of the reasons it's really great to have Catherine with us to share some of those reflections and experience. The ultimate aim is that by 2023, we'll have at least 35 units up and running, and that's the goal that we're working towards. To talk a little bit then about what the Specialist Dementia Care Program is, and if I ever lapse into using SDCP, that's what I'm saying, Specialist Dementia Care Program. The program provides aged care support for people with very severe behavioural and psychological symptoms of dementia. And that's care in a multidisciplinary team specialised in dementia and care in a dementia-friendly environment. Ash, when he talks to us, will tell us a little bit more about the cohort that this program is aimed at, but it's worth knowing that we're not talking for this program about your average person living with dementia. We are talking about people who are in the top 1% or thereabout in terms of the severity of their behavioural and psychological symptoms. And so that means that the model of care and the staff that you choose to recruit need to be specially considered to support that cohort. Another feature of the program is clinical inreach, which comes through a partnership funded by the Australian government with state or territory clinical specialists. That might be a psychogeriatrician to provide clinical advice and education for the unit. On the whole, the program aims to provide psychosocial, person-centred and goal-oriented care without restraints. The aim is to reduce or stabilise a person's symptoms within 12 months on average. That's not a strict limit. To then support the person's move into less intensive care settings following the specialist dementia care stay. The program also aims to work alongside the specialist services that state and territory governments can provide, as well as the Dementia Behaviour Management Advisory Service and the severe behaviour response teams that are operated on our behalf by Dementia Support Australia. And finally, and perhaps most importantly, the program aims to improve the quality of life for people living with very severe dementia. The program has a strong focus on ongoing care assessment and to tailor the services to the unique circumstances, background, cultural sensitivities, and preferences of each client. There is a focus on understanding the person in care, their life story, and how this may contribute to their behavioural expressions. A restraint-free way of thinking underpins service level policies and procedures and the provision of care right through the program. As a general rule, a specialist dementia care unit will consist of 9 beds, which includes 1 bounce back bed that's kept open in case the transition out isn't as successful as first planned. This number of beds isn't prescriptive, and we are open to considering a range of solutions for local contexts. We do, for example, already with Wintringham in Victoria, have a 6-bed unit that's specifically tailored mainly to people who have come from a background of being homeless or at risk of homelessness. All of the units will be expected to incorporate dementia-friendly design principles, and that's where Professor Richard Fleming will talk to us later today about that aspect of the program. I do encourage you, if you haven't already, to refer to the Specialist Dementia Care Program framework, which guides the operation of a program as a whole. One of the things that we'll do today for everyone who's registered for the webinar is send an email with some follow-up information, and that will include a link to that framework. In terms of understanding the funding for the program, it's important to recognise that the Specialist Dementia Care Program is premised on, or a top-up to, the regular aged care funding that currently is provided through the aged care funding instrument, and will in the future be funded under the new ANAC scheme. So you do need to have aged care places available, and you'll receive the normal aged care occupancy-based fees, payments, and subsidies that would be attracted to each of the individuals in care. There's also then on top of that a number of specific payments that are specifically for the Specialist Dementia Care Program. So a successful provider under the grant opportunity can apply for up to $500,000, $500,000 in establishment costs. That might be to do some capital work to get the unit ready for the cohort. It might be to do things like help with the recruitment of specialist staff, training for the staff to manage the particular cohort that will be coming in to the unit. The core of the funding for the unit is a block-funded payment of $300 per place per day. So you get that whether or not there is someone actively in the bed. And there are also then outcome-based payments for transition in and transition out of the service. And that's at a cost of $3,600 for each of the transition ins and transition outs. And that's to recognise that there's some intensive work required at both parts of the journey. And we do expect that successful specialist dementia care program providers will work with the service that receives a person after their placement for a period of 3 months to make sure that transition is successful. The full details of this grant funding and what it can and cannot be used for are found in the grant opportunity guidelines for this opportunity. And when establishing an SDCP unit, it is important to consider a business model that allows for slow, gradual growth in residents. And that's partly because of the referral and assessment process that DSA will undertake. And it does take time for those referrals to start to come in. But I know a number of the existing providers also find that they need to have a bit of time to get to know and settle in each new resident before they bring the next new resident in. So the patterns are slightly different, but they tend to build in a time between entries to allow for that transition to happen smoothly. Thanks, Fred. There are some specific requirements that go with the Specialist Dementia Care Program. We expect there to be a registered nurse on site 24 hours a day. We expect, given that there's extra funding, that there will be higher levels of staffing and particular expertise in dementia and behaviour management. We expect that each unit will establish a clinical advisory committee and have a memorandum of understanding with their local hospital or health network or whichever the relevant parties are. And that's particularly about accessing the state government specialist expertise that is available. And we expect that provision of transition out support. That said, within the framework for the program, there is a degree of flexibility for providers to determine how best to deliver that in their particular operating context. And when we're assessing the applications, we'll be assessing what you tell us about the model of care that you're planning. We will also look at things like the value for money that's presented in how you propose to use the $500,000 of setup costs. We'll expect that you are able to demonstrate for us the appropriateness of the staffing levels that you have in the unit. Now, obviously, that's for you to determine, but we do need you to show us how you're going to think about the staffing mix and ratios, how you can best then facilitate individual care plans for the people that will be coming into care. And we do expect that the block funding component will help you have a stronger multidisciplinary team around the residents in the unit. Thanks, Fred. Clinical inreach for the program is provided through the Commonwealth, funding state and territory governments directly through a project agreement. And the intent of this support is that all SDC providers will be able to access clinical specialists such as psychogeriatricians, geriatricians, or other suitable clinical specialists free of charge. So we as the Commonwealth will have an agreement with each of the state and territory governments, and then each of the successful specialist dementia care program units has their own local MOU that goes to the detail of what that support looks like and how it's accessed. We do encourage you to engage with your local health service prior to submitting an application. The purpose of this engagement is to confirm the availability and willingness of that service to provide clinical inreach, and you might want to consider including a letter of support from that local health service in your application. And we'll publish a list of key contacts with the local health services for each of the PHN target regions in this round as an addendum to the grant opportunity. We also expect that specialist dementia care units will be supported by 2 tiers of clinical support. A clinical review team, including specialist clinicians, as members of a multidisciplinary team who meet weekly to oversee the routine care of clients within the specialist dementia care unit. So that will be things like reviewing and updating care plans, identifying clients who might be ready to transition out, and advising the clinical advisory committee of those people ready to transition out. The separate clinical advisory committee is generally made up of the residential aged care service, specialist clinicians, the local health network, and often a representative of Dementia Support Australia as the organisation that provides eligibility assessment on the way in. The advisory committee is expected to meet prior to the SDCP becoming operational. Usually they would meet monthly, but that might be more frequently as the unit is established. And the purpose of that committee is to consider the suitability of recommended places. So is the person and the model of care a good fit for one another? Effectively, looking at the particular risks that a person might present, whether there are particular complexities in the care arrangements, and whether there are other external factors that might affect the decision to place a person in the unit or not. While there is that advisory committee, the Aged Care Act, which still provides the fundamental legislative underpinning for the program, ultimately makes it the final decision of the aged care provider whether or not to accept someone into their service. Thanks, Fred. The department has set up a number of support networks to assist aged care providers who are successful in grant opportunities get the units up and running. This includes a community of practice for all the current specialist dementia care units. We meet at the moment roughly every 3 months, and the Department of Health is represented. Dementia Support Australia is represented there as well, and usually Catherine and her team come along as well to talk about the evaluation and where that is up to. We are separately establishing a clinical community of practice for the state-based clinicians that are working in the units, and my team and I also meet on a regular basis with state and territory officials involved in the program. Our current grant opportunity opened on the 17th of March, St Patrick's Day, as people like to remind me, and will close on the 18th of May. The round is open in each of the regions that you can see on the screen, and it's open to any aged care provider operating in those primary health network regions. I know a couple of people have been thrown by the fact that the grant opportunity on Grant Connect refers to it being a targeted or restricted approach, and that only is referring to the fact that you need to be in one of these regions to apply in this round. There will be further grant opportunities in the next financial year as we try to fill out the remaining regions around the country. And again, we will follow up with a copy of the grant opportunity guidelines in that email coming out after today's session. I'll now hand over to Kritosh from Dementia Support Australia to talk about the target cohort for the program, referral, eligibility and assessment. Thanks very much, Ash.
Thanks, Rob. So as Rob talked about in terms of the SDCP and the Dementia Support Australia looking into assessing eligibility to access the program, I think the first thing we'll talk about is how does the different services under Dementia Support Australia fit into the different client profiles and cohorts in the model that the department follows in terms of services that are provided to people under different tiers. So on your screen, you can see the model, which is the 7-tier model of behaviors and psychological symptoms of dementia. And based on each of the tier, there is the extent of the behaviors that the person is experiencing, going from person sitting at tier 1, where there is no dementia diagnosis, to tier 2, where the person's been diagnosed with dementia. However, there are no behaviors and psychological symptoms of dementia present at that stage. As it progresses, it ranges from behaviors starting at mild to moderate and going all the way up to tier 7, which is extreme behaviors. On the left-hand side of the 7-tier model, you can see the different percentages, and what that really outlines is an estimate of people who are living with dementia, and if they do develop behaviors and psychological symptoms of dementia, would sit in that tier at any point in time. The tier of behavior is not set, so people do tend to move between different tiers. An example of that is someone could be at tier 2, where there is a dementia diagnosis, however, no behaviors and psychological symptoms of dementia. But if the person develops delirium, their behaviors could escalate and they could develop something around moderate behaviors. But once the delirium is resolved, the person could either return back into that tier 2, where there are no behaviors present, or it could even be where the behaviors are still there, so they are sitting at that tier 3. When we focus on the services, there's Dementia Behavior Management Advisory Service that supports people at that Tier 3 and Tier 4. So these are mild to moderate behaviors, people living across community, residential, and also assisting people from transitioning out of hospitals. Then at Tier 5, where the behaviors are severe, is the Severe Behavior Response Team, but for the SBRT. The SBRT team also assists people experiencing Tier 6 or very severe behaviors living in residential care. The service under DSA that focuses on assessing eligibility into the Specialist Dementia Care Program is the needs-based assessment that looks at people sitting at Tier 6 or very severe behavior. And as the model shows that this cohort of people is less than 1% of the total people who are experiencing behaviors and psychological symptoms of dementia. I'll expand a bit more in terms of what that very severe behavior looks like in the next few slides as we explore the different eligibility criteria that DSA assesses the person against to see if they're eligible to access the Specialist Dementia Care Program. Thanks, Fred. So looking at the referral and the eligibility process, as mentioned previously, so the needs-based assessment is a nationally consistent assessment program that assesses people for their eligibility into the Specialist Dementia Care Program. How the NBA does that is through looking at the 3 key eligibility criteria. The first one being that the behaviors are primarily as a result of dementia. When we explore this, it isn't discounting people where there is no definitive diagnosis of dementia. So when the consultant gets on site and explores the evidence around this criteria, it really looks into people who might also have progressive cognitive impairment. As the service is quite aware that quite often people in regional and remote areas might not have easy access to diagnostic services, or even people living in metro communities as well. Quite often they will present to hospital after an event and hence get a diagnosis quite late in their dementia progression as well. So it focuses on whether the person has dementia diagnosis, and if they don't, then looks at if there is a progressive cognitive impairment and discuss it with family and healthcare professionals in terms of what those signs and symptoms have been and how long the progression has been noted. Of course, if the progression has been very acute, which is it has only been in the last few days or weeks, it might be a sign of delirium, and that again is explored whether the person will settle once delirium is resolved or whether it truly is resulting as a sign of their dementia. This criteria, again, doesn't exclude people who might have other comorbid conditions such as mental health, ABI, or intellectual disability as well. But when we explore the evidence, it really is looking at whether the behavior for which the person is being referred is stemming primarily from dementia. So it goes and delves quite a bit into the history of the person, looks into when the behavior started that is being referred, whether there is a long-standing history of that behavior as well, if that behavior is new, when the dementia diagnosis was made, if it was made, who the diagnosis was made by and how it was made, whether there were any clinical tests, whether there was imaging, if there is suspicion of dementia, is there a medical practitioner who is suspicious that the person might be showing signs of progressive cognitive impairment? Once we explore that criteria, we move on to the next one, which relates back to the first slide that I was talking about, which looks at that 7-tier model. So the behaviors really need to sit in that Tier 6. How we explore behaviors, because the referrals can be made from people living in community or in a residential care setting or even in hospitals as well. So the idea of behavior severity is very subjective because it depends on the person who is supporting the person living with dementia, the carer. It can be a carer in the community where the experience is very limited or compared to a carer in residential care, or a carer in acute setting who is very used to supporting people living with dementia with quite severe behaviors if they are working in that unit on the ward. So DSA assesses severity across 4 domains. We look at how frequently the behavior is occurring, if it's happening every single day or if it's happening weekly, but not daily, if it was a one-off incident. Then we look into what is the nature of the behavior. So is the behavior that is being displayed verbal agitation, where the person might be making comments towards the carers or insults towards other residents, but there's no other signs of physical agitation. Then we also explore if physical agitation is the person constantly moving around their environment, they're engaging with the environment, they're moving furniture, or there's elements of where the agitation is quite severe, where certain furniture is being destroyed as well. We explore if it's physical aggression or verbal aggression. Even with physical aggression, if it's physical aggression that is in response to a situation where the person's put into distress, such as attending to personal care, or if that physical aggression is quite spontaneous to what's happening around them in the environment. The next thing we explore is what is the impact from that behavior to the people around and to the person as well. So whether if the person is living in community, can the carer look after the person, or is their carer stress noted? Is the carer stress that has increased to the point where now the carer is seeking external support through home care packages, or there is external services coming in to support the carer? Or if the person is living in mainstream residential care, the staff are struggling and they're requiring multiple staff, or there's been specialist input either through one of the other services from Dementia Support Australia, such as the Severe Behaviour Response Team or the Dementia Behaviour Management Advisory Service, or there has been local support from the mental health services or other outreach services from the hospitals. If the person is in a hospital setting, we explore again what support, what impact has the behaviour had. Do the staff require frequent use of security, or if there's been multiple code greys and code blacks? Once we've explored those three areas, we also look at what are some of the recommendations or strategies that are being in place to support the person, both looking at it from a pharmacological perspective, but also non-pharmacological as well. Have the person been engaged with other activities to help reduce the behavior? Or have there been any other use of medication as well? How frequently the medications are being used, if there's usage of quite significant PRNs, if there's usage of iron medication in the hospital as well. Once we've explored that information, we tend to capture that over a period of last 1 month from the point of referral being made. Then we move on to whether the behaviors have proved intractable to adequate trials and management. What that really means is if a specialist or a specialist service has had a go at supporting the person with their changes in behavior, but hasn't been able to have a successful outcome. This is not limited to services under Dementia Support Australia, so it can be a private geriatrician or a psychiatrist or allied health that has been looking into providing support around behaviors, or it can be services from local hospitals as well, outreach services, mental health services, or services under Dementia Support Australia. So under this category, what the assessor will really explore is the evidence of who has been involved, what the recommendations were, and what has been trialed so far, and what has been the outcome of that trial. The other key point around assessing a person is also consent. The process requires consent from the client's family or guardian or any other person who is the decision maker for the person, and also consent, what we require is informed consent, so the person being aware what they're giving consent to in terms of understanding it's a transitional program, the person is moving into another site, and as it's transitional, it means at the end of the program, once the outcomes have been achieved, the person will be moving out into an appropriate care setting, whether that is back into community or in another mainstream aged care. Thanks, Fred. So quickly looking at in terms of how does the needs-based assessment undertakes the entire process. So what you're seeing in front of you is the case management framework for NBA. It starts at triage, where we capture information against those three main eligibility criteria. Also understand if the person has an ACAS or ACAT assessment, as Rob mentioned before. The SDCPs do fall under the aged care funding, hence the person has to have an appropriate ACAS or ACAT funding so they can access the beds. Once we've understood there is consent, we move on to assessment. Generally, triage tends to happen within 1 week or sooner from the point of referral being made into DSA. So far, from the time the needs-based assessment has commenced, DSA has been tracking at an average of 3 days of completing triage. Once we move into assessment, that is an on-site assessment exploring the evidence against those three main criteria that I explained in the previous slide. So at that point of the on-site assessment, the assessor will meet with the family, will meet with the person, will meet with the staff members, explore the evidence that is either in the written form or talk to staff and gather information as evidence against those three criteria. The assessment normally takes place after 2 weeks of triage being completed. And again, consent is very important for this to go ahead. From assessment, we move on to planning. So planning really is bringing the information back that has been collected at the on-site assessment and putting it together into a report against that criteria, reviewing all the evidence, and also then discussing it with one of our specialists, whether it's a geriatrician or only a psychiatrist, to review the information provided and to make sure that the person meets all the criteria and the decision that the assessor has made is validated by the specialist as well. Once the decision's been made, whether the person is eligible or ineligible, that decision is communicated back to the referrer, outlining what the outcome is. If the person is ineligible, Dementia Support Australia then offers other alternatives of support that the referrer can access to support the person, or continue with the support that the person currently has in place. If the person is eligible, then that report or outcome is provided to the SDCP provider to discuss at the Clinical Advisory Committee. As Rob mentioned, the CAC meetings, where the decision is then made by the SDCP provider on assessing whether the person is suitable or not. And that's when the person enters the monitoring phase, which is when they are waitlisted against the SDCP until a decision is made that the person is suitable for that particular SDCP and moves into that Specialist Dementia Care Program. Once the person moves into the Specialist Dementia Care Program, the assessment process is closed and the person is successfully transitioned into the SDCP. The referrals can be made by anyone, whether it's a family member or a healthcare professional is looking after the person, and they can be made by going online to the Dementia Support Australia website, which is www.dementia.com.au, or calling in the 24/7 helpline 1800 699 799. Thanks, Fred. Thanks, back to you, Rob.
Thanks very much, Ash. Really appreciate you taking us through that. And one of the things that we'll send out with that email of resources is a link to information about the needs-based assessment process that Ash and his team use. Don't forget the question and answer function down in the bottom. I'm looking forward to some tricky ones that I can throw to the panel later in the session, so help me out there, please. Before we get to that, though, let me now introduce Professor Richard Fleming. Richard Fleming is an environmental design expert and psychologist who's been involved in the development of services for people with dementia for almost 40 years. And Richard will now present to us on dementia-friendly design principles and how they apply to this program. Thanks, Richard.
Thank you, Robert. Hello. Well, I'm very pleased to be able to give you a quick introduction to the dementia design principles. The first thing I'd like to say is please notice that it is an expectation that providers will, quote, establish an SDCP unit to deliver care in physical environments that reflect dementia-friendly enabling design principles. In other words, the application of the design principles isn't a nice to have, it's a has to have. This is because we know that a poorly designed physical environment makes it very hard for the staff to deliver the care and support that people living with dementia require, especially those with responsive behaviours. And on the other side of the coin, we also know that a well-designed environment contributes to the quality of life of people living with dementia. So could I have the next slide, please, Fred? And the first line. So what are the 10 principles of design? Well, in a nutshell, the first of them is that we must recognise that the built environment should be the concrete embodiment of your philosophy of care. That is, the starting point for good design is to have a clear idea of what model of care you want to provide for your residents. To take two extremes, if your model of care is heavily nursing oriented, your building should be designed to facilitate the delivery of nursing care. I mean, that seems obvious. If your model of care is focused on engaging people in the ordinary activities of daily living, then the design should be home-like and provide all of the resources to be found in an ordinary home. I'm sure you can see that problems arise when there's a lack of clarity about the model of care to be delivered. You can, for example, easily end up trying to engage residents in activities of daily living in an environment that is much more suited to delivering nursing care and treatments. And I'm sure there will be many people looking at this presentation who are probably in that situation themselves, where they want to deliver a model of care that simply isn't supported by their environment. So time spent on making sure everyone is in agreement on a model of care is well spent. It is then much easier to design the building because the designers will know what the building is intended to support. The other principles are even more straightforward. We go to principle 2, Fred, please. Principle 2 is about the scale of the building. Now, really, the scale of the SDP units is pretty well set from the beginning because they are restricted to around about 9 beds. So you probably don't need to worry too much about this principle. Really, what it's getting at is that a lot of research tells us that people with dementia do best in domestic scale buildings. They don't do well in large institutional buildings or buildings that are being built to impress rather than to live in. So we'll be looking for buildings that reflect a human scale, a domestic scale. Next slide, please, Fred. The buildings must also make it easy for people with dementia to find their way around, to walk around, but not just to walk around aimlessly, but to walk around in a way that engages them in meaningful activities. So the environment must provide a range of opportunities to engage with things which have some sort of attraction to and some sort of meaning for the people who are living in the place. And that movement should really be from both the inside to the outside and back in again. And that takes me on to the next principle, if you would, Fred. And that is that we must provide opportunities for residents to engage with their natural surroundings. Now, there's a sort of intuitive understanding of this. It means, that there needs to be some greenery around, some trees, some grass, some flowers, the opportunity to be outside. It's also, I think, worth thinking about, providing people with the opportunity to experience the elements, so that they're not always in a sort of monotonous temperature. They need to feel the wind, feel the natural world around them. Next slide, please, Fred. One of the most important principles is about optimizing levels of stimulation. This is really about balancing stimulation. On the one hand of the scale, we can have overstimulating environments, which are often characterized by a lot of clutter, a lot of clatter, a lot of noise, a lot of busyness. And on the other end of the scale, we can have environments which are absolutely deathly. Well, clearly, neither of those environments are conducive to a high quality of life. So we want to consciously and deliberately balance these two extremes. Next slide, please, Fred. Safety measures are important in providing high quality care to people with dementia, particularly those who have got responsive behaviors. But there is an art to providing safety measures in these circumstances. And that art is based on making sure that they are as unobtrusive as they possibly can be. It may be necessary to have doors that are locked, for example. But when that is necessary, those doors should be practically invisible, so they don't attract the attention of people. You don't have situations where people are rattling the doorknobs to try to discover what's behind the door, or even worse, trying to get out. So there's a real skill in looking around the environment, recognizing what safety measures you're putting into place, and then making them disappear. So the person lives in a relaxed environment where they're not continuously confronted with the signal, the almost subconscious signal, that they are a danger or they are in danger. Next slide, please, Finn. Enabling people to see and be seen is a very powerful design principle. What it requires is that the person with dementia can see practically everything that they want to see from wherever they are. And that might sound a really difficult thing to achieve. In practice, certainly when you're starting from scratch, it's not too difficult at all. I mean, the goal is to be able to stand in the lounge room and to be able to see your bedroom door, for example, and to be able to see the kitchen, to be able to see the dining room. So you never get lost. You can see where you want to go and you can get there easily. Unfortunately, many existing facilities haven't been designed in that way. When people leave their bedroom door and they enter the corridor, and they look in one direction, it's a dead end, and they look at the other direction, it's a T-junction. And really, there are no cues as to where to go. Well, there are ways to mitigate those circumstances, and it's very important we try to do it. But if you're in a position where you've got any leeway at all in your design, it's very, very important to design to maximize what we call visual access, to enable people to see and to be seen. Next slide, please, Fred. Familiarity is very, very important for people with dementia. As you well know, people with dementia, as the dementia progresses, revert back to earlier stages in their lives. So they find it very difficult to relate to ultra-modern gadgets and furniture and even decor. It's much more relaxing for them to be living in an environment which they can recall from their early adulthood. I mean, I'm not suggesting we create museums, but there are ways of making sure that the surroundings are familiar to the people who are living there. Next slide, please, Phil. It's also very, very important to provide a variety of spaces for people living with dementia so they can make choices, so they can choose to be by themselves, to be with one or two other people, or to be in larger groups. Preferably, these choices should be for spaces that are both internal and external. This is quite different from having one large multi-purpose room that serves as a dining room, a lounge room, and an activity room. I know that's a worst-case scenario, but from time to time they still exist. So we need to be able to see a number of spaces. And the last of the principles is that we want to avoid the situation where we're creating, I don't know what the word is, so specialized institutions which are regarded with fear and concern by local residents and places that people really don't want to go into because they have a feeling that once they go into there, they're going to lose contact with their local community, their friends, their family, their support network. In fact, we want quite the opposite. We want to create facilities, a terrible word, we want to create temporary homes where people live in a way which allows them to take as active a part in the local community as they possibly can. To have visitors freely, to live in a situation where visitors want to visit because there are facilities for them. Ideally, to have places that are so attractive that visitors will want to bring their children. If we actually have a generation of specialist dementia care units where the sons and daughters of the residents are happy to bring their sons and daughters because the children are feeling relaxed and happy and interacting in a happy way with the people living there, then I think we know we're successful. Go to the next slide, please, Ben. There's a lot of information available on the 10 principles. The Alzheimer's WA Dementia Enabling Environments website is an excellent starting point. You'll find clear descriptions of the principles and examples of them being applied in nursing homes, domestic homes, and hospital settings. And these examples are in a very clear, displayed in a very, very clear way. Next slide, please, friend. If you want to go into more detail, particularly the background and the literature and the research and the theory behind the principles, then the Alzheimer's Disease International World Alzheimer's Report 2020 is the source for you. It's got a wealth of information on the background and application of the principles. And Volume 2 has got 84 case studies from 27 countries around the world that will, I'm sure, give you, some new ideas on the state of the art of designing well for people with dementia. Next slide, please. And of course, it's very important that you have a look at the series of resources produced by Dementia Training Australia. These resources give you the tools to assess your current environment and plan your refurbishments so that they reflect the 10 principles. It's a very large set of resources entirely based on the 10 principles. And if I can have my last slide, please, friend. Let me end on the same note I started with. A good design is not just a nice thing to have. All the applications will be assessed against the 10 principles so that the staff and residents in the SDCUs will have the best chance of enjoying the time they spend in the units, and so that the residents can lead their lives to their full potential. Thank you very much.
Thanks so much, Richard. Really appreciate you taking us through all of that, and certainly the experience we've had with the program bears out the importance of design in either aggravating or soothing behavioural symptoms of dementia. And each of those resources that Richard has just taken us through will also include in that email of resources at the end of today. Let me now hand over to Catherine from Deloitte Access Economics, who'll take us through the experience of phase 1 and the work of the evaluation so far. Thanks, Catherine.
Great. Thanks, Rob. So I'm going to spend the next 10 minutes sharing some insights from the initial stages of the evaluation of the phase 1 sites. The scope of the evaluation that we're undertaking involves 3 key stages over a period of 3 years, which we commenced in 2019. The first report we delivered in 2020 was a report on the learnings from the implementation of the prototype unit at Brightwater. This included exploring questions like the appropriateness of the model of care, acceptability and adoption by consumers, experience with the needs-based assessment service and how the transition process is going. The second report that we delivered last year, was a report on the learnings from the implementation of all 10 phase 1 sites. And I'll be presenting some of the key insights from this report today. And then for the third and final phase, which is happening later this year, we will explore the outcomes and impacts achieved with a focus on the experience for residents and their families and carers, and we'll be commencing some consultations for that later in the year. So paging through, what are some of the key learnings? So rather than outlining all of the key insights today, we focus these learnings on the key findings that we think are most relevant to potential future grant recipients. And we've presented these across the following key headings: the program startup phase, the process for referrals and transitions in, delivery of care once in the unit, and the discharge and transition out process. So to start with the program startup phase, we found that it's really important that all staff receive specialised training in behavioural management prior to starting their roles. So we found that an important success factor for the experience of residents, as well as the competence and confidence of care staff and their retention, is receiving specialised training. In terms of what the type of training that this could look like, there are already lots of materials developed by the phase 1 sites that you could leverage and draw on, and the department would be happy to facilitate. So it's not necessarily something that is going to be a huge time impost. There's always the option to draw on training from DSA as well. Second, we want to note that partnerships with the in-reach clinicians are really, Fred, just back to the on the right slide. Second, we want to note that partnerships with the in-reach clinicians are key to the success of the model. So all stakeholders that we consulted with commented on the in-reach clinicians as a major strength of the program. And this is for a couple of different reasons: their ability to support seamless transitions in, particularly when the transition has originated from an inpatient facility; their ability to upskill care staff in behavioural management approaches, both formally and informally; their ability to instill confidence in families and carers on the specialised tertiary level support provided in the units despite being in a community setting; and knowledge of appropriate external and transfer out options and the important role that they play in supporting early discharge planning. So the sooner you can establish who these in-reach clinicians will be by working closely with the state mental health agencies, the better. And this includes working to identify and agree on clinical governance models, roles and responsibilities, how you'll work together as part of MOUs. And we've seen that the implementation experience was a lot more positive for those units that established these partnerships early. And on the topic of MOUs and partnerships, we'd suggest that you look to ensure that the in-reach clinicians understand that their role is not just clinical, it's also educational. So they play a really important role in informal capability building with care staff. So there's only so much that you can learn from a formal training course, particularly when it comes to understanding the types of behavioural management strategies that work for different types of residents. Often it's the type of thing that you learn on the job, and the in-reach clinicians play a really important role in the provision of ad hoc day-to-day advice to build capability. And third, might have mentioned this earlier, but don't duplicate tools and templates. You're in a really fortunate position that you are the phase 2 sites, and the phase 1 sites have come before you and tried and tested many different things. So the department hosts a really great provider community of practice to share learnings and facilitate knowledge exchange, so remember that you have that available to you. So paging through. Referrals and transitions in. So to fill the 8 beds reasonably quickly, recognise that you will need to play a role in local awareness raising and promotional activities. So the department and DSA will obviously support you in that, but there is an important local relationship building element for providers, particularly in those early stages. So some enablers to this that were cited by some of the phase 1 units included leveraging the networks of the in-reach clinicians. They often have fantastic networks, particularly with inpatient facilities, relationships with social workers who work in inpatient settings, and leveraging PHNs and their networks, particularly for to encourage referrals from community-based settings. Once you are starting to get those referrals and residents are being put forward for admission, it's important that you invest in family and carer relationships. So for many families and carers, this is a very new concept and there may be some initial reluctance, but what has really helped the phase 1 sites is offering families and carers on-site tours prior to admission to build their comfort. This is the right environment and it is very purpose-built. It's also important to manage family and carer expectations and communicate that this is intended to be a temporary transitional program and start conversations very early around what their discharge preferences might be. So if the preference for them is to transition within the village to a co-located facility, then that's good to know. Or if the preference is to go somewhere external that might be closer to home, it's good to have those conversations early so you can start planning for that and identify a suitable facility at the outset. Paging through. With regard to delivery of care, the key thing that we wanted to highlight here is that we'd really encourage you to consider a dedicated SDCP RN located at the SDCU as opposed to a co-located RN across the broader village. There's a number of reasons for this. Perceived safety is really important for care staff and has been a key driver of attrition in some cases, but having a dedicated RN at the site has really helped to mitigate against that. It also provides a really strong comfort level for families and carers as well. The RN also plays a really important educator role in building the capability of personal care attendants. And they also facilitate really strong relationships with the in-reach clinicians and facilitate timely and seamless transitions and discharges to other facilities. With regard to discharge and transitions out, the key thing that we want to highlight here is how important it is that you invest in shared care relationships with the receiving facility, particularly when transferring a resident to an external location. So this is really important for minimising bounce backs and ensuring that staff at the receiving facility are appropriately supported to sustain the impact of the program in less intensive care settings. So some units that have done this really successfully have sent their staff to the receiving facility for a couple of days to help the resident adapt and upskill the local staff on the client's unique needs and preferences, triggers, and effective behavioural management strategies. Paging through, to wrap up on a positive note, while we don't have the complete outcome evaluation report yet, that's the focus of this year. There are very early signs of strong outcomes. So overall, we found that the concept of the program has been very well received by families and carers, with offers typically only declined for distance-related reasons. We found broad consensus across stakeholders that the model is effective in achieving its goal of managing symptoms, as evidenced by NPI and H scores, the level of deep prescribing, and the number of successful transitions to date. And there have been many anecdotal stories of renewed social engagement and willingness to participate in recreational activities following many years of vegetative behaviours. And we're looking forward to evaluating this later the year and putting some numbers behind some of these outcomes. So that's it to me. I'll hand over back to you now, Rob.
Thanks so much, Catherine. And I think, I can absolutely affirm, those positive stories that we hear from the units that are operating at the moment. Wives and loved ones saying, I had my husband was really aggressive, agitated, couldn't leave his previous placement, and now after a couple of months in specialist dementia care, we can go out and have coffee together again. So some really powerful individual anecdotes that give me hope that when we get to that evaluation, we'll have some really good signs for us as well. Just a quick note that among the other resources that we'll send you about the program, we will include these other resources as well. So the program framework, a client information booklet that we've produced to help explain the program to family, and information about length of stays, fees, security of tenure, and the like. So we'll email all of those out to you as well. We have had a couple of questions come in, and I'll move to those quickly and then try not to go too far over at 3 o'clock advertised closing time. One of the questions that we have had relates to the person's contract, their security of tenure with their original provider before they move into a specialist dementia care unit. We'll include the detailed answer to that in the email that we send out, or at least the link to the information. But the short answer is that when moving into a specialist dementia care unit, a person does give up their place in the aged care. If they were in an aged care facility, they give up that place in the prior facility. That is something that's really important to explain to the family. But the other part of that is the detailed work that's part of the transition out for the Specialist Dementia Care Program, and the fact that as a successful provider, we'd expect you to work with the family to find a successful placement for the person after their stay with you. I think the only other comment I did answer it in the chat, but worth making really abundantly clear. Thank you, David, for picking me up. The closing date for applications is the 13th of May, and not the other date that I might have mentioned by mistake. So I'm really sorry about that. There is also a question there about support for successful applicants in terms of specific advice from around dementia-friendly design. We'll provide a written answer to that because it's a slightly more complicated one. I'm just going to give you 30 more seconds to pop a tricky question in for the panel before I wrap us all up. I must be going to let Catherine and Richard and Ash get off scot-free. While I'm waiting for that, can I thank you all very much for your participation and interest in the program. If you do have questions about the grant opportunity that you think about after today, you can all email those to grant.atmhealth.gov.au. That's with the grant opportunity guidelines as well. And we'll send out the information to you more broadly as well. I think by the looks of it, we don't have any other. Oh, hang on. Just having a quick look. Quick question from David on the shadow assessments and what they mean for the new funding model and what they mean. And how long from successful funding. So lots of questions for me, which is great. David, the indications that I've seen from the ANAC modelling for units is that it's better off than under ACFI for the existing specialist dementia care units under the new funding model. And that's, I think, consistent with the data that was published at budget around, on the whole, the average per bed per day being an increase. Catherine, in terms of how long from successful funding to expecting the unit to be up and running, we're hoping that we'll see units start to operate. So we're hoping that we'll be able to make offers to people in the middle of this year, so in about June, and that we can then see units starting to operate from December this year, January next year. But that's going to depend very much on the individual context of the unit and how much work is needed to get things up and running. We did have a variety of start times for the first grant round, and I expect that'll be the same for this grant round. So I think when you're applying, just tell us what you think you need to make that transition. And Nicole, in terms of your question, there's no direct role for PHNs. PHNs is how we've chosen to choose where to place units, but the clinical inreach that you'll be getting is from your local state or territory health authorities, whether that's a health or hospital service or local health district, or however that's organised. We do promote the service through primary health networks as a possible referral point, but they don't have a direct role in running the unit. And I think at that point, Catherine and Ash and Richard, you might be all off the hook. Thank you all for being part of the service today, the session today. And thank you very much, everyone, for your interest in the program, and appreciate your time. We'll call it quits at that. Thank you.